This is an approach to TB deteriorators in a clinic. There are many a patient who's been started on TB treatment, but at the clinic you find they just don't look good enough. This is a good diagram to follow in terms of trying to determine why this TB patient doesn't look good enough. In a sense, it could be a multifactorial or it could be one factor, but you need to try exclude all of them. Poor adherence is a big factor, and there are a number of reasons why patients might have poor adherence. But the one I would like to highlight is low CD4 count patients, who I find to be very forgetful, and if you ask family members, are actually quite angry at home because they know that there's a gap in their memory. So it's very important to ensure that the family observe the patient actually taking their medication until they are better enough to be trusted. Drug side effects is another common cause of why patients are not improving. Obviously, one would look for jaundice, but however, some patients are not as jaundiced as one expects. So consider doing an ALT and it might as well do a hepatitis B surface antigen also. Drug resistance is another possible cause why a patient might not be improving. So do your best to chase or repeat tests to try work out what is going on. Again, in a clinic with a patient that is not improving, one needs to consider alternative and or additional diagnoses. Quite commonly, I find with elderly patients with abnormal x-rays with a cough that they've been placed on TB treatment. However, what they're actually experiencing is a cardiac problem. Another good example is actually elderly patients with diffuse interstitial patterns on their x-ray, which is common in old people who come from rural areas, which is actually a pneumoconiosis picture, which we will nickname hut lung. And they additionally might also have a cardiac problem. So uncommonly, we might find in young patients once in a while a sarcoidosis or a lymphoma. These will only be picked up because one has an index of suspicion. Then, additional diagnosis could be, for example, Kaposi sarcoma, which you should suspect may be in a low CD4 count patient. Immune reconstitution syndrome is when the soldiers of the body wake up and fight the infection, and we give prednisone to help the soldiers walk straight. In Xhosa, Amajoni the soldiers wake up. So it's a good idea to start prednisone for patients at risk of IRIS when starting AOVs, except in the case of Kaposi sarcoma. The best time to start a patient on AOVs depends on what kind of TB, what their CD4 count is, and clinic factors. For example, would one want to start on a Monday and follow them up during the week, or a Friday? It depends on the clinic situation. If you have a patient with TB abdomen, please consider giving additional Maxilon and Lansoprazole. As an aside to this whole diagram about TB deteriorators, just know that when patients are initiated on antiretrovirals, they can complain of an itch or worsening PPE, and giving them some low dose prednisone does help them with the symptoms. In patients with extensive PPE all over their body, consider giving them a mixture of 4 tubes of any strong corticosteroid ointment in 500 grams of emulsifying because this also helps settle down their PPE. Increasing the dose of rifampicin is always a very useful consideration in any TB patient. You can easily increase the dose by 150 milligrams over national guidelines, and waiting for blood levels is just a waste of time at a clinic level. I find it particularly useful to increase the dose of rifampicin in young men who have strong pharmacokinetics because their rifampicin levels tend to be lower and they significantly feel much better if you increase their dose. Patients with low CD4 counts don't absorb rifampicin well, and they also feel much better if you increase their dose. And TB meningitis patients, I also think, do much better with higher rifampicin dose. Another scenario at the clinic level of a patient not looking good enough is iron deficiency while they're on TB treatment. Now, traditionally, we don't start iron treatment whilst people are being initiated on TB treatment. However, after 2 weeks, I safely consider introducing it if the patient clinically is pale or have the ability to interpret a full blood count for the patient. When interpreting the full blood count in a patient who is on ARVs, there is a phenomenon where the MCV does increase when the patient is on ARVs. So when you see a normal MCV with a low HB in a patient who is on ARVs, consider that this is actually microcytic in this particular patient. Additionally, you can look at the range as the MCV is just an average, and if the range is wide, then you would consider that there are nutritional and iron deficiency elements to this problem. So don't hesitate to start iron tablets. And by this, I'm assuming that you've excluded other possible causes, for example, a drug-induced anemia. Follow-up and continuity of care are the keys to a confident clinical experience in dealing with patients who do not look good enough at the TB clinic.